Today we're talking about the best blood pressure for adults 60 and older. Most people think that blood pressure is black and white. There's either a normal number and a high number. But here's the truth. Blood pressure is one of the most personal numbers in all of medicine. And two people with the same number can have completely different risks.
The best blood pressure for someone over the age of 60 is not a number printed in a pamphlet. It is not the number your neighbor brags about at the pharmacy. It is not even the number your doctor circled on a chart 10 years ago and told you to maintain forever. It is a number that belongs to you, only you. And understanding why that matters could be the difference between living well into your 80s and ending up on a hospital floor wondering what went wrong. I spent years working inside emergency rooms, and in that time I watched two very different kinds of patients come through those doors, both of them suffering, both of them scared, and both of them connected to the same silent problem: blood pressure. The first group made sense to most people. Years of high blood pressure, ignored or undertreated. And then one day, a stroke, a heart attack, kidneys slowly shutting down. These were the patients people expected to see, the ones the textbooks warned about. But the second group, that is the one that stopped me cold every single time. These patients came in confused, disoriented. Some of them had fallen. Some had cracked their skulls on bathroom tiles. Some had blacked out mid-sentence. And when I checked their blood pressure, it was not high at all. It was dangerously low, not because of neglect, but because someone had pushed it there, with medication, with the best of intentions, and with no real understanding of what that particular body could and could not handle. One group was harmed by doing nothing. The other was harmed by doing too much. That tension, right there, that is the whole story. And if you are a senior, or if you love someone who is, what I am about to share with you is not just important, it is urgent. Because the guidelines most doctors still use were not built with your body in mind. And following them blindly could cost you something that no pill can give back. I have spent over a decade in emergency medicine. I have seen what happens at both extremes, and I am here to walk you through exactly what the research actually says, what it quietly leaves out, and what the right blood pressure target genuinely looks like after the age of 60. Not according to a pamphlet, but according to your life, your body, and your specific situation. Stay with me, because what comes next will completely change how you think about this number. Hi viewers, I have a quick question for you. When you check your blood pressure, do you feel reassured or worried by what you see? Drop your answer in the comments below. I read every single one, and your answer might just shape what I cover next. Now, before we go any further, I need to make one thing absolutely clear. Your blood pressure is a snapshot, a single frozen moment. It tells us the pressure inside your arteries at that exact second. But here is what it does not tell us. It tells us nothing about the arteries themselves, nothing about their condition, nothing about how they are aging, nothing about what they can still handle. Think about that for a moment. Two people, same reading, 120/70. Side by side on paper, they look identical, but inside one of them, the vessels are soft, elastic, responsive, pushing blood up to the brain smoothly and efficiently, even when that person stands up quickly. Inside the other, the vessels are stiff, narrowed, hardened by decades of wear, and that same pressure is barely enough to get blood where it needs to go the moment gravity enters the equation. Same number, completely different bodies, completely different risk. That is not a small distinction. That is everything. And here is the part that changes as you age. Arterial stiffness increases with time. It is not a disease, it is biology. But it means that the rules shift. A reading that is perfectly safe at 40 can become a liability at 75 if the vessels behind it have changed and the medications in front of it have not. So when I am thinking about an older patient, I am not looking at a number on a screen and deciding whether it is good or bad. I am asking a much harder question. What is this number actually doing inside this specific body? Is it feeding the brain? Is it keeping this person steady on their feet? Or is it slowly stealing something from them that nobody has noticed yet? That question does not have a one-size answer, but it does have an answer, and we are going to find it together. Here is the truth about the research that started this entire conversation. And I mean the real truth, Not the headline version, not the summary that gets passed around in waiting rooms and printed on hospital leaflets. The actual findings, with the parts that most people never hear. In 2015, a landmark study called the SPRINT trial was published. It involved more than 9,000 adults over the age of 50. Researchers split them into two groups. One group aimed for a systolic blood pressure below 120, the other aimed for below 140, and the results came back looking very clear. The lower group had fewer heart attacks, fewer strokes, fewer cardiovascular deaths. On the surface, it looked like a closed case. Lower is better, push the number down. Done. But wait, read who was actually in that study. The SPRINT trial deliberately excluded people with diabetes. It excluded people who had already experienced a stroke. It excluded people with dementia. It excluded those with advanced kidney disease. And it excluded anyone classified as significantly frail. So what the trial actually proved was this: aggressive blood pressure lowering helps relatively robust, relatively healthy older adults. That is a very specific group. And that group is not the same as every senior sitting in a doctor's office today being handed a new prescription. That distinction gets lost almost every single time this trial is mentioned, and that loss cost people dearly. Then in 2021, a study called the STEP trial came out of China. Similar design, adults aged 60 to 80, similar findings on the surface. The group pushed toward 120 had fewer heart attacks and fewer strokes. But buried inside those same results was something the headlines did not shout about. That same group had more episodes of dizziness, more strain on the kidneys, more people feeling faint, more people feeling unsteady. So you gain protection against one threat, and you quietly raise your exposure to another. That is the trade, and nobody tells you about the trade. The lower target protects your heart in one direction while creating new danger in another. And the entire challenge of managing blood pressure in older adults is learning how to weigh those two sides against each other for each individual person. Not for a category, not for a demographic, for a person. Because medicine at its best is not about categories. It is about the specific human being sitting in front of you. Now I want you to hold that thought, because what I am about to tell you next is the part that changes everything about how you think about falls, about independence, and about what aggressive treatment can quietly take away from someone without anyone realizing it until it is far too late. Here is something that does not make it into research papers often enough. Falls are not minor events. Not when you are over 70. Not when you are on multiple medications. Not when your bones have thinned and your reflexes have slowed and your arteries no longer snap back the way they once did. I have seen it more times than I can count. When blood pressure is pushed too low in an older person, the brain is the first organ to raise the alarm. And the reason is simple. The brain sits at the top of the body. Gravity works against it constantly. Every time you stand up from a chair, from a bed, from a toilet seat, your body has to respond instantly. Your arteries have to constrict. Your heart has to adjust. Blood has to be pushed upward against gravity in a fraction of a second. In a young, healthy, elastic system that happens automatically. You never even notice it. But in an aging system with stiffened vessels and medications already pulling pressure downward, that response slows. And in that small window of delay, the brain gets less blood than it needs. And that is when the room starts to spin. That is when the knees buckle. That is when the lights at the edge of your vision start to flicker and fade. And sometimes that is when someone hits the floor. A fall at 80 is not the same as a fall at 30. A broken hip in an older adult carries a 1-year mortality rate that rivals some of the most serious diagnoses in medicine. A head injury in someone taking blood thinners, medication for the heart, medication for clotting, medication that many seniors are already on, can result in a bleed that moves faster than any surgical team can respond to. These are not rare outcomes. These are the outcomes I watched play out inside emergency rooms. Regularly. And the cruelest part, the medication that caused the fall was prescribed to protect them. That is not negligence. That is a system treating a number without fully accounting for the person attached to it. Your arteries are not passive pipes. They are living, responsive, intelligent tissue. They squeeze, they relax, they adapt, they compensate, and that compensation is what keeps you upright and clear-headed and functional. But that responsiveness erodes with age. And when we stack aggressive medication on top of an already compensating system, we are not helping it. We are overriding it. And overriding a system that is already working hard to keep someone safe is not always brave medicine. Sometimes it is reckless medicine dressed up in good intentions. What falls steal that no study measures cleanly is independence. The person who falls once starts to fear falling again. They move less. They go out less. They stop trusting their own body. And that loss of movement, that withdrawal from physical life, accelerates muscle loss, bone loss, cognitive decline, and cardiovascular deterioration all at once. The quiet downward spiral that follows a single fall can be more damaging than the fall itself. And it can all begin with a blood pressure target that was never designed for that particular body in the first place. So how do you know if this is happening to you or someone you love? Your body will tell you. The problem is that the signals get dismissed, written off as just getting older, accepted as the new normal when they are anything but normal. Pay attention if you feel strong lightheadedness the moment you stand up, the kind where you reach for something solid just to stay upright. Pay attention to dizziness in the mornings, to a brain fog that seems to track with medication changes, to fatigue that arrived around the same time a new prescription did, to that unsteady feeling on your feet that was not there a year ago, to home readings that keep dropping below 100 systolic. These are not small complaints. These are your body sending a message that the current target is costing more than it is saving. Lower pressure is only a win if you feel well at that pressure. The moment it takes your steadiness, the equation has flipped. And that flip matters. Now, let us talk about what the right numbers actually look like. Because this is where I want to give you something genuinely useful. Not a category, a framework, a way of thinking about your own situation that you can bring into a real conversation with your own doctor. If you are between 60 and 79 and you are walking regularly, living independently, your thinking is sharp, your kidneys are functioning well, and you are not on a long list of medications, then a target around 130/80 is a reasonable and well-supported goal. You may even tolerate lower than that and see real cardiovascular benefit from it. Your physiology likely has the resilience to handle a more aggressive approach. That is the kind of person the sprint trial was actually studying, and for that person, the evidence is strong. But now picture someone in that same age range who carries several chronic conditions, someone on 4 or more medications, someone whose kidney function is borderline, someone who already experiences occasional dizziness. For that person, chasing 120 is not ambitious. It is dangerous. A target closer to 140/90 gives meaningful protection against stroke and cardiovascular events without pushing that already strained system past what it can safely manage. And then there is the group that the medical system has historically handled the worst. Adults over 80. Once you pass 80, the calculation shifts entirely. Most experienced geriatricians, the doctors who specialize in older adult care, are comfortable with a systolic pressure somewhere between 130 and 150, and they are guided far more by how that person feels day to day than by hitting a precise figure on a machine. If you sit lower than that range and you feel genuinely well, no dizziness, no unsteadiness, well hydrated, sleeping adequately, then that is likely fine and probably beneficial. But the target in this age group follows your symptoms, not the other way around. The number serves you. You do not serve the number. This is not a prescription. This is a framework. And it is one that must always be taken into a conversation with your own doctor who knows your history, your medications, your body, and your circumstances in a way that no video ever could. What I want you to do is take this framework in with you. Walk into that appointment armed with something real. Measure your blood pressure at home. Do it every day for a week. Same time each day, same arm, same seated position. Write down your readings, average them, and alongside those numbers, write down any symptoms you noticed. Any dizziness, any unusual fatigue, any moments of unsteadiness. Because when you walk into that office with a week of home readings and a list of how your body has been responding, you have transformed a guessing game into an informed conversation. You are no longer a passive recipient of a prescription. You are an active participant in your own care. That shift, that single shift in how you show up to that appointment, changes everything about the quality of the decision that gets made. Now, here's the part of this conversation that I saved for last, because it reframes everything that came before it, and I want it to land properly. There are two ways to lower your blood pressure. Two completely different roads that lead to the same number on the screen, and the difference between them is not small. It is enormous. And understanding it might be the most important thing you take away from everything I have said today. The first road is natural. Movement, real consistent physical activity, aerobic exercise, walking, swimming, cycling, combined with resistance training that builds and maintains muscle. A way of eating built around vegetables, fruits, legumes, whole grains, and a deliberate reduction in excess sodium paired with an increase in potassium-rich foods. This is not a trend. The research behind it is robust. A major analysis published in the journal Hypertension found that regular aerobic and resistance exercise can lower systolic blood pressure by several meaningful points on its own. The DASH dietary pattern, which has been studied extensively in controlled trials, has shown similar reductions. These are not small effects. In some cases, they are large enough to remove the need for one medication entirely. But here is the deeper truth about the natural road. When you lower your blood pressure through years of moving well and eating well, you are not just moving the number. You are repairing the system that produces the number. Your arterial walls become more elastic. Your vascular reflexes, the ones that keep you upright when you stand, get sharper and faster. Your kidneys function better. Your nervous system regulates pressure more efficiently. The lower reading is a reflection of a healthier body. There is no hidden cost. No side effect waiting around the corner. Now take the second road. Medication. I want to be completely clear here. Medication saves lives. I'm not dismissing it. I prescribe it. I believe in it when it is right for the right person. But I want you to understand what medication does and does not do. When I bring your blood pressure down with a tablet, the number on the screen looks exactly the same as if you had earned it through a year of walking and eating well. Identical. But underneath that number, nothing has been repaired. The arteries are still stiff. The reflexes are still slow. The system is still struggling. I have simply placed an override on top of it, and that override carries a price. The dizziness, the dry cough that comes with certain medications, the kidney strain, the pressure crash when you stand up too fast, the fatigue, the foggy thinking that some people never connect back to the pill they started 6 months ago. Same destination, two completely different journeys. One leaves the body stronger, one leaves the body unchanged and adds new complications to manage. If you have the ability to earn that lower number, earn it. If you have the years and the physical capacity to build toward it naturally, that path is always safer, always. It is not always possible. And medication fills the gap when it is not. But the goal should always be to need as little of it as necessary by giving your body every natural advantage available. That is not idealism. That is evidence-based medicine. And now let me bring this full circle, because I want to leave you with something that goes beyond numbers and trials in medication lists, something that sits underneath all of it. We are not treating a reading, we are treating a person who wants to stay sharp, who wants to stay mobile, who wants to stay in their own home, in their own life, on their own terms for as long as biology will allow. The number on the blood pressure cuff is one piece of information in service of that larger goal. It is not the goal itself. The guidelines give us categories, and categories are useful starting points. But a category is not a treatment plan, and a number on a screen is not a patient. The real work is matching the target to the body, watching how that body responds, and being willing to adjust when it speaks. Know your numbers, measure them regularly, understand your baseline so that any change means something instead of surprising you. Because if you have no idea what your normal looks like, then every reading is just noise. But if you have tracked yourself over weeks and months, then a shift becomes a signal. And signals save lives. Get your blood pressure under control, move your body, protect your vessels, feed the system that keeps you upright and thinking and present. And when you sit down with your doctor, bring the data, bring the symptoms, bring the questions, because the best blood pressure for a senior is not a universal number. It is the number that keeps your brain fed, your feet steady, your kidneys protected, and your life genuinely yours. That is what good blood pressure looks like after 60, not a target on a chart, a life that keeps going.